Thank you so much for the invitation and the very kind introduction. I'm glad to be here. And what we want to see is whether it's really important when we talk about psoriasis. We know in atopic dermatitis, always a big subject, whether it's also important to talk about itch and pain in psoriasis. No conflict of interest for this talk. So there are several publications already demonstrating that itching, as you can see here on the left side, as well as pain, play a role, but the numbers are also varying depending on which population is studied, and also psoriatic arthritis is also included. And on the right side, you can also appreciate that pain is a significant problem for many patients, as well as also itch for more than 50% of the patient, also from doctor perspective as well as from patient perspective. And also, Gil Josipovic and his group, they were studying whether the DLQI is not only correlating in the improvement with the PASI score, but also with the itch score, and could show that also the itch plays a role, at least in some of the patients, for the improvement of the DLQI. So it's really important also to look into that. And there are also anecdotal studies from the last decades, as these two patients, for example, where there was a neuropathy and traumatic nerve palsy, and showing that in these where the nerve palsy was current, that also the psoriasis was asymmetric and different. So whether there is a communication between the immune cells, the vasculature, and the nerves, that was then to be understood. And there were 10 years ago was a study from Harvard showing, at least in the mouse model, that nerves are capable to activate dermal dendritic cells to release IL-23 and to develop in the mouse a psoriasis phenotype. Whether this is a primary effect, secondary effect also, and that can be translated to human disease, of course, still has to be verified or falsified, but at least we have some evidence. There's a cross-communication between immune cells and nerves. And what is important is that this communication is bidirectional. So the nerves can activate receptors on immune cells, aggravating, perpetuating inflammation, and also T cells, as well as dendritic cells, innate lymphoid cells, are capable of activating receptors on sensory nerve endings, perpetuating inflammation, also inducing itch and pain. So let's talk first about pain. Especially clinically, one can see it where there are fissures, and I don't talk here so much about psoriatic arthritis because of the time. But the mechanisms are very similar. So you have activation of C fibers, A delta fibers, then you have peripheral activation, sprouting of nerve fibers, central sensitization, and also the brain plays a role in the perception and also perpetuation of chronic pain. And then you can distinguish based on the nerves which are activated. You can see several subtypes, whether it induces a sharp pain, a dull or burning pain, or also an inflammatory pain. And I want to focus here more on the inflammatory pain because I think that's specific in psoriasis, but also the dull and sharp pain is important because there are different phenotypes. So here you can see this is a busy slide, many receptors on the sensory nerve endings. We all know that antihistamines are not very effective in psoriasis, so histamine receptors don't play a role in itch or in there. And also in pain, we know that there are many receptors. And very interesting is in recent years we have learned that even chemokines and cytokines are capable of activating specific receptors on nerve endings. And we have shown a couple of years ago that the TNF receptor is also communicating with TRP ion channels, which are very important pain channels, directly to communicate to induce pain. Then there's a second level which we also have to consider when we talk about chronic pain. We all know from post-herpetic neuralgia where we need gabapentin or SSRIs to treat this severe pain, and the pain and the itch in the dorsal horn of the spinal cord changes the plasticity during chronic pain. And luckily in psoriasis we don't have these kind of problems as in atopic dermatitis or other diseases, but still we need to consider sometimes that also chronic pain can lead also to the use of medications which are beyond the peripheral treatment, like gabapentin, for example. So let's talk about itch. As you can see here in this post-stroke itching patient, itch can be a very severe symptom which can lead to damage and also psychological and physical stress. So itching should not be underestimated, and often as physicians we underestimate how much patients are suffering from the severe itching, as you can see in these two examples. So it's important to talk about itch, and what we also have learned in recent years, what you can see here in the peripheral nerve, there are many, many receptors. So there's not only histamine receptors, there's also toll-like receptor, proteases, cytokine receptors, prostaglandin receptors, etc., ion channels, which can be activated in this inflammatory soup of a disease, which then activates secondary signaling mechanisms. And then even in the spinal cord level and on the brain, we have several mediators. So we still do not understand fully what is a CTCL itch, what is an atopic dermatitis itch, a psoriasis itch, and how do they differ from each other, and how do they need to be treated differently from each other. But we are getting closer to this. And also important is to mention that these receptors can be also interact with each other. So in psoriasis we also have the Koebner phenomenon, and we know that scratching can also induce itching. And a couple of years ago we have looked, for example, in damaged keratinocytes, where we looked at upregulation of the keratinocyte and could show that TLR3 is upregulated, for example, in atopic dermatitis, and releases itch mediators such as endothelin and TSLP, which is an important cytokine also in many diseases, and that leads to the nerve activation and itching and scratching. So also we know that scratching can lead to itching and a reactivation of the nerve, and understanding that this is a vicious pathological cycle. So in the periphery, whether it's psoriasis, atopic dermatitis, we now know there are many mediators, not only proteases and peptide, but also cytokines, which then activate the sensory nerve ending, leading to itching or pain, and also releasing then neuropeptides and talking back to the immune cells via neurogenic inflammation, such as a Th17 cell, for example, and aggregating, perpetuating. And also the keratinocyte, like in psoriasis, for example, can release mediators which directly activate high-affinity receptors on the sensory nerve endings. Bernhard Homay and Dr. Zonkoli have studied a couple of years ago and compared psoriasis and atopic dermatitis, and I just want to show you here that we are getting closer also on the PCR level. Each column is one patient, and as you can see here, for example, for IL-31, that an IL-31 receptor, that psoriasis had not a lot of release of IL-31, which is the case in atopic dermatitis. So it will be very fascinating in the future, and that hasn't been done for psoriasis, also to study the psoriasis cytokines in order to identify more the itch and pain pathways in psoriasis. Proteases has been shown many publications that it plays a role in psoriasis in many areas, and one of the mechanisms how proteases, which are activated by the keratinocytes, can induce neuroinflammation and itching and pain, is also via the PAR2 receptor, which has been cloned about 20 years ago, and it directly activates sensory nerve ending and contributing to itch and pain, but also to neuroinflammation and also release of cytokines such as IL-1, IL-6, etc., IL-8, which are involved in psoriasis. So let's go to the clinic and the therapy and how can we translate it into clinical. And this is one of the psoriasis patients which had an itch score of 10 out of 10 and was suffering a lot from this itching more than even of the skin lesion. And the itch was very well controlled using anti-IL-17 therapy and also indicating that the new medication, anti-IL-17, IL-23, also contribute to the alleviation of itching and even pain, so they are involved. But in which way, whether it's directly or indirectly, is still poorly understood. One study, which we have published a couple of years ago, for example, comparing also etanercept and ixekizumab, definitely has shown that also ixekizumab as an anti-IL-17 therapy has a possibility also to alleviate itching, and even more, the more severe the itching was also, the better anti-IL-17 therapy was working, indicating that IL-17 may be involved. And there's an anti-IL-17 receptor also expressed on DRG neurons, so it could be a direct effect. And supporting this is also from other studies. We know that zicokinumab, for example, also can have a beneficial effect on itching, and this Australian study analysis has shown that there are still patients where even if I treat them with anti-psoriasis therapy, anti-TNF, anti-IL-17, that not always the itch reduction correlates with the current biological therapy. So not 100% of the patients can be controlled also with the most modern therapy. So that's why probably we need sometimes additional therapies in the future. There are some medications on the way which may control, such as the trip ion channels, opioid pathways, cannabinoid pathways, and then the cytokine pathways, of course, which we need to understand better, and the proteases which play a role in psoriasis. And last but not least, we also know that many of these cytokines signal through the JAK-STAT pathway, so it could be also that some of the JAK inhibitors which you're using also may contribute to the alleviation of pain and itch in psoriasis, and also to an anti-inflammatory capacity, and also addressing neuroinflammation, what we know in atopic dermatitis, that the JAK inhibitors are also very important by regulating the neuroinflammation component of the disease. So in summary, we can say that, that many of the modern medication which we are using in psoriasis may address itching and pain pathways, and that also in severe patients, maybe we still need adjunctive and new therapies in order to control this potentially debilitating symptoms in psoriasis. Thank you very much.
Thank you very much, Professor Martin. Maybe we have time for one question, maybe. Does anybody has an urgent question? I know we're short of time, but maybe one. Okay. Yeah.
Joel Gelfand from Philadelphia. It's a very nice talk. One I just want to mention for the audience, the word psoriasis means itch in Greek. That's the origins. Most people don't realize that. Yeah. So itching is a big part of this disease. Do you have patients who you clear the skin and then they still have significant itching? And then how do you address it?
Where they still, the signs are improving the psoriasis lesion and still have itching?
Correct.
Yes.
Yes, yes, it is. Yeah, especially the scalp area, also the groin area. There are still, and especially where I see patients who have more dry skin. And I think that's somehow also related to the keratinocyte. It is not as severe as in non-lesional skin as atopic dermatitis, but still there are some patients, but less. But they are, and I think there is still the cytokines are a little bit different, probably because also you see that the skin is then a little bit, it's a little bit more dry, and also they have more scalp involvement.
So do you sometimes add JAK inhibitors or add an IL-31 biologic?
Yes, very good question. Then I often use additional JAK inhibitors. Now also upadacitinib have been shown also to work in psoriasis, and that's actually very fast improvement then.